Hello and welcome back to the deep dive. Today we are locking the doors, turning off the notifications, and entering what I like to call the bunker.
The pre-exam bunker. I know it well.
If you're listening to this, there is a very, very high probability that you are currently staring down the barrel of the MD anesthesiology exams.
Probably the Gujarat University papers, maybe the national boards.
Exactly. The coffee is probably cold, your eyes are tired, and you've got a stack of textbooks on your desk that, I swear, weighs more than a small child.
It's a familiar feeling, a visceral one, that mix of, adrenaline and just pure dread. You're trying to cram 3 years of residency into a 3-hour paper or a 20-minute viva. It's daunting.
It is. And today we are tackling a topic that strikes fear into the heart of even the most prepared resident. We're talking about the intersection of high-tech physiology and pure survival skills.
We're talking about echocardiography and left ventricular assist devices, LVADs.
Yes. We've pulled from the heavy hitters for this one. Miller's Anesthesia, Morgan and McHale, ICU Protocols by Dilip Kumar, and the absolute classic Yao and Artusios.
And this isn't just a random topic selection. We need to be clear about that. This is strategic.
How so?
If you look at the trends in recent exams, the examiners have moved on from simple stuff like, the pharmacology of ficostigmin. They want to know if you can handle complex, modern cardiovascular physiology.
They want to know if you can function in a 2026 operating room.
Exactly. An OR, where the patient might have a mechanical pump instead of heartbeat.
So that's the mission today. We're going to try and synthesize these thousands of pages into a kind of survival guide. We need to cover the definitions that get you the marks, the views you'll be asked to draw, and the specific Viva traps.
The traps that examiners just love to use to filter the distinction candidates from everyone else.
And we need to do it in a way that actually sticks, not just a dry recitation. We need to visualize this stuff.
You have to. Because in the exam, especially that table Viva, they're going to hand you an image, a loop, and you have about 10 seconds to orient yourself before the silence gets very awkward.
Right. Let's start with the big picture then, the context. Why is this topic, echo and LVADs, exploding right now? I mean, 10 years ago, echo was purely the domain of the cardiologist, wasn't it?
Oh, absolutely.
Yeah.
The anesthetist would just kind of look at the screen and nod politely.
And hope they weren't asked any questions.
That era is completely over. Miller makes a very, very aggressive point about this. Anesthesia has evolved from being a reactive specialty, treating hypotension after it happens, to a proactive diagnostic specialty.
So getting ahead of the problem.
Precisely. Echocardiography has moved out of the dark echo lab and right into the OT in the ICU. It is now considered a basic monitoring skill. It's almost on par with pulse oximetry.
Wow.
I mean it. If you're a senior resident in 2026 and you cannot put a probe on a chest to see if the heart is empty or full, you are arguably practicing below the standard of care.
So it's really the difference between guessing and knowing.
100%.
Yeah.
In the old days, BP drops, you give a slug of ephedrine. Maybe it works, maybe it doesn't. You don't really know why.
You're just treating a number.
You're treating a number. Now you look. You put the probe on. Is the heart collapsing on itself? Give fluid. Is the heart boggy, big, and failing? Give an enotrope. You're treating the actual physiology.
Okay, and what about the second half of our topic, the LVADs? How do they fit into this new world?
That's a numbers game. Heart failure is an epidemic. We're getting better and better at keeping people alive, but donor hearts are incredibly scarce.
So we're turning to mechanical solutions.
We have to. We're implanting mechanical pumps. And these patients, they're living for years now. They're getting out of the specialized cardiac centers and coming to general hospitals for life. For gallbladders, for hip fractures, for car accidents.
And you, the anesthetist on call at 3 a.m., will be the one managing a patient with no pulse who is wide awake and talking to you.
It's a terrifying thought for the uninitiated, absolutely.
Yeah. Okay, let's get very practical. The exam structure. Where does this topic show up?
It's everywhere. In the theory papers, this is prime territory for a 20-mark long answer.
Like what?
The classic is, describe the anesthetic management of a patient with an LVAD for non-cardiac surgery. That's a gift if you're prepared. Or discuss the role of T in cardiac surgery.
And in the practicals.
The table Viva.
That's
Without a doubt. They will slide a picture of a D-shaped ventricle across the table, stare at you, and just ask, what's going on, candidate?
Okay, let's do this. Let's build it from the ground up. Section 1, echocardiography. We're in the Viva. The examiner looks at you over their glasses and asks, candidate, define echocardiography. What is the sentence that needs to come out of our mouths?
You need to sound crisp, Confident,
Yeah.
no waffling,
Right.
you say. Echocardiography is the imaging of cardiac structure and blood flow using ultrasound waves,
Okay.
typically in the frequency range of 2 to 10 megahertz, and generated via the piezoelectric effect.
Let's pause on that. Piezoelectric. That feels like one of those buzzwords that separates a pass from a good pass.
It is. You have to say it.
So what does it actually mean in simple terms?
It's the physics of the crystal inside the probe. There are these special ceramic crystals. When you apply an electric current to them, they physically vibrate, they expand and contract, and that creates the sound waves.
And the other way around?
Exactly. When the sound waves bounce back from the heart and hit those same crystals, they vibrate again and generate a tiny electric current. The machine then translates that electricity into a pixel on the screen.
And the frequency range you mentioned, Dennis, 2 to 10 megahertz. Why that specific range? Why not, say, 20 or 1?
This is a trade-off. It's a favorite concept for the more physics-minded examiners.
Okay.
High frequency gives you fantastic resolution, beautiful, crisp images, but it has very poor penetration. It can't travel far through tissue.
And low frequency.
Is the opposite. Great penetration can see deep into the body, but the images are blurrier, less detailed.
So for a TTE, a transthoracic echo through the chest wall.
You need penetration. So you're going to use lower frequencies, maybe 2 to 5 megahertz, because you have to punch through skin, muscle, ribs, and lung.
But for a T, a transesophageal, where the probe is right next to the heart.
Now you can crank it up. You can use higher frequencies, 5 to 7, even 10 megahertz, to get those crystal clear, high-definition images because there's almost nothing in the way.
Which brings us neatly to the two main players, TTE and T. Let's distinguish them for the exam.
TTE, transthoracic, is the non-invasive workhorse. It's what you do in the ICU or the pre-op clinic. It's quick, painless, no sedation needed.
Right, the PSOTUS stuff, point-of-care ultrasound.
Exactly. ICU protocols really emphasizes TTE for the FATE or FALLS protocols, rapid assessment of a patient in shock. But it has a major Achilles heel.
The poor window.
The poor window. Ultrasound hates two things, air and bone. So if your patient has COPD with hyperinflated lungs, the air just scatters the ultrasound waves. It's like trying to see through fog. If they're morbidly obese, the fat attenuates the signal. If they have a fresh sternotomy dressing or chest drains, you physically can't put the probe where you need it.
And that is where T enters the chat, so to speak.
Transesophageal.
Yeah.
It is semi-invasive. You have to be clear about that. We act a bit like gastroenterologists and guide a probe down the esophagus.
But the view.
The view is unparalleled. Because the esophagus lies directly posterior to the left atrium, there is nothing in the way. No ribs, no lung, no fat. Miller states unequivocally that T is the gold standard for intraoperative monitoring in open-heart surgery and for any hemodynamically unstable patient where TTE is inconclusive.
Okay, this is critical. I want to role play the views viva. This is where candidates really sweat. The examiner hands you a probe, or maybe just a pen pretending to be a probe, and says, show me the parasternal long axis. Walk us through the physical movements.
All right, visualize this with me. You're standing at the patient's right side, usually. For the parasternal long axis view, or PLAX, you place the probe on the chest, just to the left of the sternum.
Which rib space?
Usually the third or fourth intercostal space. Now, the crucial part, the orientation marker. Every probe has a little light or a groove on one side.
Okay.
For PLAX, that marker must point towards the patient's right shoulder.
Right shoulder. Got it. And what are we slicing? What's the plane of the image?
Imagine a knife slicing the heart from the right shoulder down towards the left hip. You're cutting the heart in half lengthwise.
So what structures do we see on the screen?
From top to bottom, the first thing you see is the right ventricle, because it's closest to the probe on the chest wall. Then you see the interventricular septum, then the big left ventricle, and at the bottom, the posterior wall. To the right of the screen, you'll see the aortic valve and the left atrium.
So why do we care about this view? What is it good for, specifically?
It's the contractility view. Miller points out it allows you to see the anteroseptal and inferolateral walls perfectly. You can instantly see if the heart is squeezing well or if a segment is down.
Is there a limitation?
Yes, and it's a key one. You cannot see the apex of the heart in this view. The slice just doesn't hit it. So if the patient has an apical infarct, you'll miss it completely in the PLAX view.
Okay, next move. The examiner says, good. Now show me the short axis. What do?
You don't move the probe from its location on the chest. You just twist your wrist. You rotate the probe 90 degrees clockwise.
So the marker that was pointing to the right shoulder is now pointing where?
Now it's pointing to the patient's left shoulder.
Okay.
You've gone from slicing a melon lengthwise to slicing a loaf of bread. This is the parasternal short axis, or PSAX.
The famous donut view.
That's the one. And you can scan up and down the heart like an elevator just by tilting the probe. If you tilt up towards the base of the heart, you see the aortic valve.
Stop there. The aortic valve, you have to describe the shape. That's a classic question.
It is. In diastole, when the valve is closed, the three leaflets, the right, left, and non-coronary cusps, close to form a Y shape. In systole, they snap open to form a triangle. This is the classic Mercedes-Benz sign.
I've definitely heard examiners ask this follow-up. What if it looks like a football instead of a Mercedes sign?
Then you are dealing with a bicuspid aortic valve. Only two leaflets instead of three. That's a very common congenital defect, and it's prone to early calcification and stenosis. It's a big finding.
Okay, let's take that elevator down from the aortic valve. What's next?
You tilt the probe down a bit, and you're at the mitral valve level. It's like a fish mouth, opening and closing.
And then further down.
You go down further to the mid-papillary level. And this is the money shot. You see the left ventricle as a perfect circle of donut. The papillary muscles are at roughly 4 o'clock and 8 o'clock.
Why is this view so important?
Yao and Artuzio stresses that this is the single best view for assessing global LV function. Because in this one single slice, you can see territories supplied by all three major coronary arteries at the same time.
So if that donut isn't squeezing symmetrically, you know you have a regional problem.
Instantly. You can see it immediately. Now let's move to the apex.
Okay, new position on the chest.
Yes. You physically move the probe to where you can feel the heartbeat, the point of maximal impulse, or PMI. Usually that's the fifth intercostal space, mid-clavicular line.
And the marker.
Point the marker towards the bed or the patient's left axilla. This gives you the apical four-chamber view, the A4C.
This is the one that looks like the classic diagram of a heart you see in textbooks.
Exactly. You see the septum vertically in the middle of the screen. You've got the LV on the right of the screen, the RV on the left, and the two atria at the bottom. Shows all four chambers at once.
And what's the primary use of this view?
This is the comparison view. You are looking at the relative sizes of the ventricles. Normally, the LV is the big, muscular brother. The RV should only be about 2/3 the size of the LV.
And if they're the same size? Or if the RV is even bigger?
That is RV dilation. That's a massive red flag. You have to immediately think about causes of acute right heart strain.
Like a pulmonary embolism.
Pulmonary embolism is number one, but also severe pulmonary hypertension or an RV infarct.
Okay, last of the basic views, the subcostal.
For this one, you put the probe just under the xiphoid process, that little bone in the bottom of the sternum. You press down firmly and aim the beam up towards the patient's left shoulder.
And the trick here is using the liver, right?
You got it. The liver acts as a perfect acoustic window, letting you see the heart from below. This is the essential view in trauma as part of the FAST scan and in the ICU.
Why is this so critical in those settings?
Because you are looking for fluid in the pericardial sac, pericardial effusion. Gravity pulls fluid down so it collects right there between the liver and the heart. It's the first place you'll see it.
It's also where we look at the IVC, isn't it? The inferior vena cava.
Yes. From the subcostal position, you just rotate the probe slightly, and you'll see the big IVC tube entering the right atrium. We watch it breathe.
What are we looking for?
If you ask the patient to take a quick sniff, the negative intrathoracic pressure should cause the IVC to collapse. If it collapses completely, they are dry. Their CVP is low.
And if it doesn't collapse?
If it's big and fat, we call it plethoric, and it doesn't move with respiration, then their CVP is high. They are full, maybe even overloaded. It's a quick and dirty volume status assessment.
Okay, that's a fantastic tour of the views. Now let's talk parameters, what we are actually measuring. The examiner asks about systolic function. We all know the term ejection fraction, but just saying EF isn't going to be enough for a pass, is it? How do we quantify it properly?
Right. In day-to-day clinical practice, honestly, we often just eyeball it. We say it's good, bad, or ugly. But for the exam, you must cite the proper method.
Which is?
It's Simpson's method of discs, or the biplane method of discs.
Okay, unpack that. It sounds like a geometry problem from school.
It pretty much is. The machine traces the endocardial border, the inner lining of the LV cavity, at the end of diastole and the end of systole.
In which view?
That's the key. It uses two different views, usually the apical 4-chamber and the apical 2-chamber. It then slices that 3D shape into a stack of, say, 20 imaginary discs, like a stack of coins. It calculates the volume of each individual coin and adds them all up.
To get the total volume.
To get the end-diastolic volume, EDV, and the end-systolic volume, ESV, then the formula is simple. EF equals EDV minus ESV divided by EDV.
Why is that better than the older methods?
Because it accounts for the fact that the ventricle isn't a perfect bullet shape, especially if there are regional wall motion abnormalities where one part of the heart is bulging out. Simpson's method is much more accurate.
I remember Yao and Artuzio also mentions another metric for the short axis view, FAC.
Fractional area change. It's a simpler 2D version. You just trace the area of that donut hole in the mid-papillary view.
Okay.
You do in diastole and in systole. The formula is area in diastole minus area in systole divided by the area in diastole. It correlates pretty well with EF, and it's quicker to do if you only have a good short axis view.
Now we're entering the danger zone. Diastolic function, I feel like this is the topic where most residents start to stutter. It feels like a black box.
It is complex, absolutely. But let's try to simplify it for the Viva. When you think about diastole, you're really thinking about two separate things.
What are they?
First is relaxation. Is the heart muscle actively untwisting and expanding after it squeezes? And second is compliance. Is the heart muscle wall stiff or is it pliable?
Okay, relaxation and compliance. How on earth do we measure that with sound waves?
We look at the pattern of blood flow across the mitral valve. Imagine you were standing in the left ventricle looking up at the left atrium.
Okay.
When the mitral valve opens, blood rushes in. This first rush happens because the ventricle is actively relaxing and sucking blood in. This creates the E wave on the Doppler trace, E for early filling.
And then?
Then there's a brief pause called diastasis. After that, the atrium contracts to squeeze the last bit of blood into the ventricle. This is the A wave, A for atrial kick.
So on the screen we see two bumps, an E wave and an A wave.
Exactly. And the ratio between them tells us a lot. In a healthy young heart, the ventricle sucks like a vacuum. The relaxation is vigorous. So the E wave is huge, and the atrium doesn't have to do much work.
So E is bigger than A.
Right. The EA ratio is greater than 1. Now, as we age, or if we develop hypertension, the ventricle starts to get a bit stiff. It doesn't relax as well.
So the E wave gets smaller.
It shrinks. And now the atrium has to work harder to push blood in. So the A wave gets bigger, the ratio flips. Now E is less than A. This is grade 1 diastolic dysfunction, or impaired relaxation.
But there's a trap here, isn't there? Something called pseudonormalization.
This is the Viva distinction question?
Yeah.
Absolutely. If the heart gets really stiff and non-compliant, the pressure in the left atrium starts to build up massively to try and force blood into that stiff ventricle.
So the pressure upstream gets very high.
Very high. And that high upstream pressure forces the mitral valve open hard, creating Tahal E wave again. So the pattern looks normal, E is greater than A, but it's for a pathological reason. The heart is actually an advanced diastolic failure.
So how do we tell the difference? How do we distinguish a truly normal heart from a pseudonormal failing heart?
We have to use a different tool. We stop looking at the blood and we start looking at the tissue itself.
Yeah.
We use something called tissue Doppler imaging, or TDI.
And what are we measuring with that?
We put a little cursor on the mitral valve annulus, the ring of muscle that the valve sits in, and we measure how fast that muscle is moving up and down. We call this velocity E, or E prime.
What does that tell us?
In a healthy, relaxing heart, that muscle ring moves quickly, so E is high. In a stiff, failing heart, the muscle moves like a brick. It's very slow, so E is low.
So the blood flow, the E wave, might look normal because of high pressure, but the muscle speed, the E, reveals the truth about the underlying stiffness.
You've hit the nail on the head. And this leads to the holy grail number in diastology, the E over E ratio.
E.
You take the blood velocity, E, and you divide it by the tissue velocity. And there's a magic number.
Which is?
If the E ratio is greater than 15, it's a very strong indicator that the filling pressures in the left ventricle, the LVEDP, are high. The patient is in significant diastolic failure.
And if it's low?
If E is less than 8, you can be confident that the filling pressures are normal.
That is a brilliant, concise, high-yield nugget of information. E's greater than 15 means high LVEDP. That's one to memorize.
Absolutely.
Okay, let's move into the OT. We're in the middle of a case. The patient becomes hypotensive. The surgeon immediately says, it's your anesthesia. You say, no, you're bleeding somewhere. How does echo settle this classic argument?
Echo is the ultimate referee in the operating room. You put the probe on the chest.
Scenario A.
Scenario A. The heart is small, it's hyperdynamic, beating very fast, and the walls are literally touching each other in systole. We call this kissing papillary muscles.
And the diagnosis is?
The tank is empty, The patient is profoundly hypovolemic, the surgeon is wrong, or there's occult bleeding they haven't found yet.
So the treatment is obvious,
Fluids.
and lots of them.
Okay, scenario B. You
Right.
put the probe on, the heart is big, it's boggy, and it's barely squeezing at all. The EF looks terrible.
Diagnosis.
That's pump failure, myocardial depression, or a stun.
And the treatment is the opposite.
Completely. You give inotropes to butamine, epinephrine, do not give more fluids. You'll cause florid pulmonary edema.
And the third possibility, scenario C.
You put the probe on, the heart is squeezing beautifully. It's not empty, it's not overloaded, but the BP is still 60/40.
What's the diagnosis there?
That's a pipes problem. Vasodilation. It could be sepsis, an anaphylactic reaction, or, yes, maybe it is an overdose of anesthetic agent.
And the treatment is?
Vasopressors, phenylephrine, norepinephrine. Squeeze the pipes.
It just simplifies the differential diagnosis of hypotension so beautifully.
It takes the guesswork out of it.
Now, Miller mentions something about ischemia monitoring that I find absolutely fascinating. It says echo can detect ischemia earlier than the ECG. How is that possible?
It's because of something called the ischemic cascade. It's the sequence of events that happens when a coronary artery gets blocked. The very first thing that happens, within seconds, is metabolic changes at the cellular level. We can't see that. But the second thing, within a minute or two, is mechanical dysfunction. The wall of the heart supplied by that artery stops moving properly.
And the ECG changes.
Electrical changes on the ECG, like ST depression, are the last thing to happen. They can take 5, 10, even 15 minutes to appear.
So if you're watching the heart continuously with a T probe,
You will see a regional wall motion abnormality, an RWMA, develop in real time. You'll see a segment that stops contracting, we call that akinesis, or even bulges out paradoxically, which is dyskinesis.
and you'll see that minutes before the ST segment monitor on the ECG starts to alarm.
Minutes. It's a huge safety margin. It's the most sensitive monitor for intraoperative myocardial ischemia, period.
That's incredible. Let's shift gears slightly to the ICU and the emergency setting. We need to talk about two specific pathologies that examiners absolutely love because they have such distinct, classic echo signs.
Tamponade and pulmonary embolism.
Let's start with tamponade. The examiner asks, what are the echo signs of cardiac tamponade?
Right. So obviously the first thing you see is a pericardial effusion, fluid around the heart. But you have to say this. Fluid alone does not equal tamponade.
So what's the diagnostic sign?
The truly diagnostic sign is diastolic collapse of the right atrium and the right ventricle,
Why specifically in diastole?
because that's when the chamber pressures are at their lowest. That's the filling phase. So the high pressure from the fluid in the pericardial sac is high enough to crush the thin-walled right heart when it tries to relax and fill.
Are there other signs?
Yes. You'll also see a plethoric IVC, a big fat IVC that doesn't collapse with respiration because the downstream pressure is so high.
Okay. Now for pulmonary embolism. A massive PE. What are we going to see?
In a massive PE, the right ventricle is trying to pump against a suddenly clogged lung circulation. The pressure in the pulmonary artery skyrockets. The RV can't handle it.
So it stretches out.
It dilates massively. Remember we said normally the RV should be 2/3 the size of the LV. With a big PE, the RV becomes bigger than the LV.
And what does that do to the septum?
That high pressure in the RV pushes the interventricular septum over into the left ventricle. So in the short axis view, the round LV donut gets squashed into a D shape, the D-shaped septum.
And there's a specific named sign as well. Something McConnell.
McConnell sign, yes. This is highly specific for an acute PE. You see akinesis, like a movement of the RV free wall. It's just stunned. But weirdly, the apex of the RV is still contracting vigorously.
So the main wall is dead, but the tip is still wiggling?
It looks like the apex is winking at you. That's the description.
Why does that happen?
The theory is that the apex of the RV is sort of tethered to the hyperdynamic LV, which is trying to compensate, so it gets pulled along for the ride, while the stunned free wall is just dead in the water.
The winking apex. I will never forget that now.
It's a memorable sign.
Okay, before we leave echo entirely, let's do a little bit of math. The examiner asks, can you calculate cardiac output with echo?
Yes, you can. And it brings us right back to high school physics, really, the formula for flow in a cylinder.
Which is?
Volume equals area times length.
How does that apply to the heart?
In the heart, stroke volume equals the cross-sectional area, or CSA, of the aortic valve or the LV outflow tract, multiplied by something called the velocity time integral, or VTI.
VTI sounds intimidating.
It's not as bad as it sounds. It's simply the distance that a column of blood travels with each beat. The machine calculates it for you if you trace the Doppler waveform of flow through the valve.
So you get the stroke volume.
You get the stroke volume. And then cardiac output is just stroke volume times heart rate. It's a fantastic way to monitor a patient's response to therapy.
Yeah.
You give fluid bolus. Does the VTI go up? If yes, they were fluid responsive.
Okay, and one last formula, the Bernoulli equation.
The modified Bernoulli equation. This is what we use to estimate pressure gradients across tight valves, like in aortic stenosis.
And the formula is?
Pressure gradient, or delta P, equals 4 times the velocity squared. So delta P equals 4v222.
Can you give an example?
Sure. Let's say you measure the velocity of the jet of blood shooting through a stenotic aortic valve, and it's moving at 4 meters per second.
Okay.
So you square the velocity. 4 times 4 is 16. You multiply by 4. 16 times 4 is 64. That means the pressure gradient across that valve is 64 millimeters of mercury.
Which is severe aortic stenosis.
That is severe aortic stenosis. It's a simple formula, but you absolutely must know it for the Viva.
Okay, everyone, take a deep breath. Shake it out. We have, I think, conquered the mountain of echocardiography. But now we have to cross the valley of death.
Left ventricular assist devices, LVADs.
This is where everything we just spent all this time learning about normal cardiac physiology gets flipped completely on its head.
It really does. This is the science fiction portion of the exam. Except it's not science fiction anymore. It's real life.
Let's start at the beginning. Define an LVAD for us.
An LVAD is a mechanical pump that is surgically implanted into the chest. A cannula, which is basically a rigid pipe, is cored into the apex of the left ventricle.
So it goes right into the heart muscle.
Right into the tip of the LV. It sucks blood out of the ventricle, spins it through a small motor, and then shoots it out into the ascending aorta via an outflow graft that's sewn on.
So it's effectively bypassing the failing left ventricle.
Completely bypassing it. The LVAD does all the work.
Who gets these devices?
There are 2 main groups of patients. The first group is what we call bridge to transplant, or BTT.
Meaning?
These patients are dying of end-stage heart failure. They are on the waiting list for a donor heart. The LVAD is a temporary bridge to keep them alive and well enough for surgery until that call comes.
And the second group?
The second, and now much larger group, is destination therapy, or DT.
So this is permanent.
This is permanent. These are patients who are too old or too sick with other comorbidities to be considered candidates for a heart transplant. The LVAD isn't a bridge to anything. It's their final solution. And Miller notes that destination therapy is the fastest growing indication.
And these are the patients we're going to see.
These are the patients you will see coming in for appendectomies, for hip replacements, for anything.
Let's talk about the hardware itself. We used to have pulsal pumps, the first generation.
Right, the first generation.
Yeah.
These were huge, bulky things that either sat outside the body or were implanted in the abdomen. They had diaphragms and valves, and they pumped like a heart, thump, thump, thump.
So you could feel a pulse with those.
Yes, you could. But they had so many moving parts. The bearings and valves would wear out. They were prone to mechanical failure and thrombosis.
So we moved on to continuous flow devices.
This is the modern era. Devices like the HeartMate 2, which is an axial flow pump, and the newer HeartMate 3, which is a centrifugal flow pump.
Explain the difference in the mechanism.
Think of the HeartMate 2 as a propeller in a tube. Blood comes in and is shot straight out, like a torpedo. The HeartMate 3 is more like a spinning disc. Blood comes into the center and is flung out to the sides by centrifugal force.
But the key concept is the same.
The key concept is that inside the pump is a single moving part, the impeller, which is suspended in a magnetic field. It just spins at thousands of RPM. It doesn't beat, it just flows.
And because it flows continuously?
The patient has no pulse.
I really want to linger on this for a second because it's so counterintuitive. You walk up to a patient, they are sitting up in bed, reading a magazine, talking to you. You grab their wrist to feel for a radial pulse, and there is nothing.
Absolutely nothing. You put a stethoscope on their chest.
Yeah.
You don't hear lub-dub. You just hear a mechanical hum, like a small refrigerator. It is profoundly disturbing the first time you encounter it.
So if there is no pulse, how does the physiology even work? How is blood getting to the organs?
It relies on a constant pressure gradient, not a pulsatile one. And this brings us to the 3 fundamental rules of LVAD physiology. You have to know these codes.
Okay, what are they?
1, they are completely preload dependent. 2, they're very afterload sensitive. And 3, they are totally at the mercy of the right ventricle.
Let's break this down. Rule number 1, preload dependent.
The pump is set to a fixed speed, let's say 5,000 RPM. It's a dumb machine. It will try to suck and pump whatever's presented to it.
Okay.
If the patient gets dehydrated or they're bleeding during surgery, the left ventricle starts to get empty. But the pump doesn't know that. It keeps sucking at 5,000 RPM. It sucks the walls of the ventricle together.
And that's called a Verstine.
A suction event. The inflow cannula gets blocked by the collapsing heart muscle. Flow through the pump stops. The patient can get ventricular arrhythmias. It can physically tear the endocardium. It's a disaster.
So rule 1 is keep the tank full.
Keep them full, absolutely.
Okay, rule number 2, afterload sensitive.
The pump has to push blood out into the aorta against the systemic vascular resistance, the SVR.
Right.
If the patient gets stressed or gets light under anesthesia and clamps down their blood vessels, hypertension, the resistance rises. A continuous flow pump struggles to push against high resistance. The flow drops, the motor works harder, and you can overload the left ventricle.
So rule 2 is don't let them get hypertensive.
Keep them soft. Keep the afterload low.
And the third rule, the right ventricle, you said it's the weak link.
This is the single most critical concept for an anesthetist to understand. The LVAD fixes the left side of the heart. It's a perfect pump. But where does the LVAD get its blood from?
From the left ventricle.
And where does the LV get its blood from?
The lungs.
And who pumps blood to the lungs?
Or right ventricle.
The poor, forgotten right ventricle. If the RV fails, for any reason, the LV doesn't fill. If the LV doesn't fill, the LVAD has nothing to pump. The patient dies. It's that simple. Miller states that RV failure is the leading cause of perioperative morbidity and death in LVAD patients.
The RV is king.
The RV is everything.
Okay, let's put this into practice. We have a patient with an LVAD, and they're scheduled for a laparoscopic cholecystectomy. We're seeing them in the pre-op clinic. We obviously check the patient, but we also have to check the machine. We look at the controller, the little computer they wear. What numbers are we looking for?
You will see 4 key numbers displayed on that screen. You need to know what they are and what they mean.
Number 1?
Speed, measured in RPM. This is the fixed setting that the cardiologist has programmed. It's usually somewhere between 8,000 and 10,000 RPM for a HeartMate 2. You do not touch this unless you are specifically told to by the LVAD team.
Number 2.
Flow, measured in liters per minute. This is your effective cardiac output. It should usually be between 4 and 6 liters. But, and this is a crucial note for the exam, this is an estimated number. It's not directly measured. The machine calculates it based on speed and power.
Okay. Number 3?
Power, measured in watts. This tells you how much electrical energy the motor needs to use to maintain its set speed.
And number 4?
The Pulsatility Index, or PI. This is a dimensionless number that gives you an idea of how much the native heart is contributing to the overall flow.
Let's go back to power. Explain what a change in the watts reading might mean. What if it suddenly spikes up?
Okay, think about using an electric blender. If you're blending water, it's easy, the power draw is low. If you stick a big spoon in it, you create friction, and the motor has to work much harder to spin. The power usage goes way up.
So a spike in watts in an LVA
Suggests a pump thrombus. A blood clot has formed on the impeller inside the pump, creating friction. It's a very ominous sign.
And what if the power suddenly drops?
That means the pump is spinning freely with no resistance. It's like the blender is suddenly empty. In an LVAD, that suggests a suction event. The pump is sucking against a collapsed ventricle.
Okay, and the pulsatility index, the PI. If the flow is supposed to be continuous, why is there any pulsatility at all?
Because the native heart is still in there. It's still trying to beat feebly around the inflow cannula.
Right.
If the native heart has some residual function, it adds a little kick or a little pulse of flow. With every beat it manages to generate, the PI will be higher, maybe 4 to 6.
And if the native heart is completely shot?
If the native heart is dead or stunned, or if the pump is doing 100% of the work, then the flow is perfectly flat and continuous. The PI will be very low, maybe 2 or 3.
So a sudden drop in the PI during a case could mean?
It could mean the native heart is failing. Or, more acutely, it could mean the pump is sucking the ventricle dry and there's no native ejection happening at all.
Okay, let's go to the OT. We're about to start the case. Intraoperative management. What is our mantra for these patients?
I tell my residents to remember 3 words: full, soft, and right.
Full, soft, and right.
Full means maintain their preload at all costs. They cannot tolerate hypovolemia. Soft means keep their afterload down, keep their mean arterial pressure between 70 and 80 millimiri Hg, avoid vasoconstriction,
And right.
protect the right ventricle at all costs.
How do we do that? What are the specific strategies to protect the RV?
The RV is a WIMP. It's a thin-walled chamber that hates pumping against high pressure in the lungs. So you have to avoid anything that increases pulmonary vascular resistance.
Which means?
1. avoid hypoxia. Low oxygen is a potent pulmonary vasoconstrictor. 2. Avoid hypercapnia. High CO2 is also a potent pulmonary vasoconstrictor. 3. Avoid acidosis for the same reason.
To keep the ventilation and oxygenation perfect.
Perfect. And be very proactive with inotropes that support the RV. Don't be shy. Start a milrinone or a dobutamine infusion early if the RV looks even slightly sluggish on the echo.
What about the anesthetic induction itself?
You have to be incredibly gentle. A rapid bolus of propofol is a disaster. It causes massive vasodilation, which drops their preload and afterload, and it's also a direct myocardial depressant. That's a triple hit.
So what's a safer choice?
Yao and Artuzio often suggest etomidate because it's so cardiostable, or a very, very slow titrated induction with small doses of whatever agent you choose, watching the hemodynamics like a hawk.
Now for the monitoring nightmare. We put the standard BP cuff on the arm, and it just reads error. We put the pulse oximeter on the finger, and we get an erratic, unreliable signal. How do we measure blood pressure?
You absolutely cannot rely on an automated NIBP cuff. It's designed to detect oscillations from a pulse, and there are none. You must use a Doppler.
So you need a manual cuff and a pencil Doppler.
Yes. Here's the technique. You place a manual sphygmomanometer cuff on the arm. You take your pencil Doppler probe, put some gel on it, and find the radial artery at the wrist. You'll hear the continuous whoosh, whoosh, whoosh of the LVAD flow.
Okay.
You then inflate the cuff until that sound disappears completely. Then you very slowly deflate the cuff. The exact moment you hear the whoosh return. That number on the dial is your pressure.
Is that the systolic pressure? Diastolic?
It is neither. Because the flow is continuous, the pressure is effectively the mean. That number is your mean arterial pressure, your MAP.
And what's our target MAP?
The sweet spot is generally between 70 and 80 millimeters of mercury. If it's too low, say less than the 65, you're not perfusing the brain and kidneys. If it's too high, over 90, you're creating too much afterload for the pump, and you risk a hemorrhagic stroke.
What about an arterial line?
It's essential for any major surgery.
Yeah.
But you have to be prepared for what you're going to see on the monitor.
A flat line.
It'll be an almost flat line, or maybe have some tiny irregular ripples on it from the pump's impeller. That is normal. Do not try to fix the damping or call the technician.
Let's talk about complications. What are the big things that kill these patients?
It's the eternal, terrible balance between bleeding and clotting.
Right. They're all on anticoagulants.
They're all on warfarin or Coumadin. Their target INR is usually pretty high, 2.0 to 3.0.
Mm-hmm.
But here's the fascinating and terrifying part. Nearly all of them also develop an acquired von Willebrand syndrome.
Why does that happen?
It's purely mechanical. The impeller is spinning at 9,000 RPM. That creates massive shear stress on the blood components as they pass through. It physically chops up the long, delicate chains of von Willebrand factor proteins.
And without von Willebrand factor?
Platelets can't stick together properly to form a primary plug. So even if their INR is in the therapeutic range, they have a profound platelet dysfunction. They are incredibly prone to nasty bleeding nosebleeds, GI bleeds, hematuria.
And the inverse risk, the clotting side.
Pump thrombosis. If they stop their anticoagulation, even for a short time, or if they get a systemic infection, a clot can form on the impeller. That can seize the pump completely, or it can break off and shoot a clot into the brain, causing a massive stroke. It's a constant high-wire act.
Okay, let's talk about the ultimate code blue scenario. You're in the ICU, you look at the monitor, the arterial line is flat, the ECG shows fine ventricular fibrillation, the nurse starts screaming, "Cardiac arrest!" What do?
The first thing you do is STOP. Take a breath. Do not jump on the chest. Step 1, look at the patient, not the monitor. Are they pink? Are they breathing? Are they trying to talk to you?
And if they are?
If yes, then you do absolutely nothing. They're in VF electrically, but the LVAD is pumping blood and perfusing their brain. They are effectively alive. This is the great LVAD trap. The ECG means almost nothing for perfusion in these patients.
Okay, but what if they are unresponsive, they look blue, and they're not breathing?
Now it's a real emergency. Step 2, put your stethoscope or even just your ear on their chest. Do you hear the hum of the pump?
What if the pump is still humming?
If the pump is humming, it's not a pump failure. It's likely a physiological problem. A massive PE, a suction event, tamponade. You treat the cause.
And if the pump is silent?
If the pump is silent, the machine has stopped. Now you're in real trouble. And now comes the great controversy, CPR.
What's the issue?
Miller specifically warned that doing chest compressions can dislodge the inflow cannula from the apex of the ventricle, causing a fatal hemorrhage into the chest. It's a crash the plane to save the pilot kind of situation.
So what's the current guideline?
The current AHA guidelines generally say, if the patient has no signs of life and you cannot immediately restart the pump by checking the driveline and power source, you perform chest compressions. You have no other choice, but you do it knowing the risks.
That is an incredibly high-stakes decision tree.
It is.
Let's bring echo back into the LVAD discussion. How do we use T intraoperatively for these patients? What are we looking for?
Two main things. First is cannula position. You use the echo to make sure that inflow pipe is pointing straight at the mitral valve, sucking blood from the main pool, and not pointed at the septum or the free wall where it can get obstructed.
And the second thing?
We look for septal shift. This is the key visual. It tells you everything about the balance between the left and right sides.
Explain that.
In a normal heart, the septum is pretty much in the middle or bows slightly into the low-pressure RV. In an LVAD patient, if you see the septum is sucked flat or it's bulging over to the left,
What does that mean?
it means the LV is empty and the RV pressure is too high. This is either a suction event from hypovolemia or it's a sign of acute RV failure. Both are emergencies.
And if the septum is bulging the other way, to the right.
That means the LV is overloaded and distended. This could mean the pump speed is set too low, or the pump is stopped, or the outflow graft is kinked.
And what about the native aortic valve? Do we want it to be open or closed?
This is a great Viva question. Ideally, we actually want the native aortic valve to open just a little bit, intermittently, maybe once every 3 or 4 beats.
Why?
It helps to wash out the aortic root. If the valve stays permanently slammed shut because the LVAD speed is too high and it's decompressing the LV completely, the leaflets can fuse together and a thrombus can form right on top of the valve. That's a ticking time bomb.
This has been a massive, massive download of information. Let's try to create some audio cheat sheets for people to use for revision, a quick fire comparison. TTE versus T.
Okay, TTE, non-invasive, available everywhere, great for screening, and post-US, limited by poor windows from air and bone. T, invasive, requires sedation or GA. The gold standard for intra-op monitoring gives an unparalleled view of all the posterior structures, like the mitral valve and the left atrial appendage.
Perfect. Next comparison. Pulsatile LVAD versus continuous flow LVAD.
Pulsatile LVAD, that's the past. They were large, noisy, you could feel a palpable pulse, but they had high rates of wear and tear and mechanical failure.
Continuous flow.
Continuous flow, that's the present and future. They're small, they're quiet, the patient is pulseless or has very low pulsatility, and they are highly durable because they only have one moving part.
Fantastic. And finally, let's list the top 3 Viva traps. The things that really annoy examiners and can get a candidate into trouble.
Number 1, without a doubt, is ignoring the right ventricle. If you discuss the management of an LVED patient and you don't use phrases like RD protection strategies or mention avoiding hypoxia and hypercapnia, you will fail.
Number 2.
Immediately treating hypotension with a pure vasopressor like phenylephrine. If the LVAD is in a suction event because of low volume, squeezing the SVR will only make things worse. The answer is almost always volume first, assess with echo, then decide on pressors.
And the third trap.
Misinterpreting the flat arterial line on the monitor as a systole or a damped trace. The examiner is waiting for you to say, I would first check the patient. If they are awake and talking, the monitor is correct.
Before we sign off, I want to give the listeners a tangible to-do list, something to do the second this deep dive ends. Grab a piece of paper and a pen.
Good idea.
1. Draw the Mercedes-Benz sign of a normal aortic valve in short axis. 2. Try to sketch the pressure-volume loop of a heart supported by an LVAD. Hint, it's a triangle. The isovolumetric phases disappear because the pump is always on.
And a third thing.
Go on.
Write this down in big letters and stick it on your wall. MAP in an LVAD patient equals Doppler return of flow.
Visualization is everything.
It is. If you can draw it, you understand it. If you understand the underlying physiology, you can talk your way out of any corner the examiner tries to paint you into.
Well, good luck to everyone out there sitting the Gujarat University exams, the national boards, any exam. You have done the work. Now go and crush it.
Trust your preparation. You've got this.
Thanks for listening to The Deep Dive. We'll see you on the next one.